As we're gradually moving back to opening schools and businesses, and of course, our in person interactions, I want to remind you this is all time with cold and flu season getting going. Staying hydrated is key to helping your body deal with the added stress and with the upcoming flu season. My regular fans have heard me talk about a product called Hydrolyte for a long time now. It's an amazing rapid rehydration drink. It's a mix that, well, we're obsessed with here. I'm excited to announce they've just released Hydrolyte Plus Immunity just in time for cold and flu season. Hydrolyte Plus Immunity starts with their fast absorbing electrolytes and adds a host of immune boosting ingredients. Each single serve, easy pour drink mix contains 1,000 milligrams of vitamin C and 300 milligrams of elderberry extract, creates what is hopefully immune boosting formula that's high in antioxidants and zinc. Combining this with Hydrolyte's 7 key electrolytes, it's a fantastic way to stay proactive and properly hydrated. Hydrolyte Plus Immunity comes in convenient, easy to pour powder sticks that rapidly dissolve in water and make a great tasting drink that has 75% less sugar than your typical sports drink. It uses all natural flavors and it is gluten free, dairy free, caffeine free, non GMO, and it is vegan. And you can find Hydrolyte Plus by visiting hydrolyte.com/Dr. Drew. Again, that's HYDRALYTE.com/DRDRW. And be sure to use our code Dr. Drew 25 at checkout for a special discount.
Hello, everyone. It's a dose of Dr. Drew.
Indeed, and don't forget our friends at Seed. I use their product every day, as well as the UVC light from iWand, and of course Halidine, which is my new companion when I travel, which is to prevent viruses and other infecting agents from getting set up in our nasal pharynx. There's things that I'm doing differently now because of COVID, and UVC light and Halidine are definitely one of them. And of course, I've said before how Hydrolyte saved me, and yeah, and I use Seed on a regular basis. I would like some more, Susan, if you could arrange that.
We're working on it.
All right. So I'm looking at the stream here, and of course, I'm still fatigued and having trouble with all my post-COVID stuff. So I apologize for any cognitive, chugging that goes on here. And I would say I'm already chugging. There's a new study that came out called the Siren Study. I forget exactly what SIREN stands for. It's essentially SARS coronavirus reinfection rate. And it showed that in hospital workers, among several thousands of them, the reinfection rate after 5 months was about 0.66%, suggesting that we have good immunity. And by the way, those that did get sick got lesser COVID, which is interesting in and of itself. So that we're looking like we have good immunity for at least 5 or 6 months. And perhaps we can avoid taking the vaccine for a while. And by the time that 6 months is up, I will be looking at that Novavax vaccine pretty carefully. So without further delay, I want to bring my special guest in here. This is Dr. Emily Porter. She's an emergency room physician. She's been over a decade of experience there. She has other talents in terms of the realm of sexual health, which I did not know about, but a lot of products you are using are stuff that we've supported over the years. And I caught Emily on Twitter, and I thought, I need to talk to my peer. I need to talk to Dr. Porter. And thank you for joining us.
Thank you for having me.
So the main thing, we'll get into all kinds of stuff, I'm sure, but the main thing that caught my attention was, I don't know if I wrote the tweet down, but it was essentially what you were saying about the amount of resources that go into training a physician, and that they have sidelined that resource or exposed that resource unnecessarily to danger. Witness one right here. I couldn't get the vaccine. You have had COVID recently for different reasons, but you should have been vaccinated, and you should remain out there in the world working as a resource in this horrible epidemic. But the people that are making these decisions, I don't know what their priorities are. What do you say?
So I actually I've gotten both of my vaccines now.
Oh boy.
But I got COVID between vaccine 1 and 2.
Got it.
Probably exposed by my son, who had symptoms like on the 19th of December. And then I got my first Pfizer vaccine on the 22nd. So it just hadn't had time to work yet. It'd been 3 days. It needs minimum 2 weeks to do anything. My husband, same thing. He'd been vaccinated on the 17th and was exposed the 19th. So we all tested positive the week of Christmas. And we think, just hadn't been enough time. So that was really, really unfortunate timing with the vaccine. Yeah, we got it pretty quickly, but
But what about that tweet? What were you
Yeah.
thinking? Yeah.
What I was thinking is that I have so many colleagues right now who are so burnt out. They've been felt mistreated for a long time. I think online reviews, I think telehealth, and just feeling like there's so many other ways for people to see a physician, and corporate medical groups. There's a million reasons why people have been feeling demoralized. But then all this, it takes 11 years to make a doctor,
Right.
minimum.
Minimum.
4 years of undergrad, 4 years of medical school, minimum 3 years of residency. Realistically, a lot of them are 5. If you do a surgery,
a lot longer than that. But yes,
yeah,
I'd
6
say
years
average is
if you
probably
had a
4.
fellowship. And so what I said is that just realize that if you burn people out or demoralize them, corporate medical group or whatever you are, the public, and people start quitting in droves and leaving medicine, you don't want to do that in the middle of a pandemic, because it's an 11-year fix minimum to replace us. And so don't drive people to desperation or kill them off by not giving them PPE or not having them be vaccinated, but then asking them to go out and work and expose themselves, because you can't just reproduce us overnight.
Right. I remember early in my career, I was meeting with a hospital administrator, and I told him, I go, whatever I know, it's clearly not special because it's not being treated as special. I just feel like I'm a completely disposable sort of unit here at the hospital. And he was like, oh, that's true. We have to change that. Of course they didn't. Things have gotten way worse then, especially in primary care. At least in ER, you kind of you kind of know what you're dealing with. In primary care, it's constantly getting screwed down with 20 years of rhetoric, which how much we have to support primary care. We need to get involved in reimbursing primary care. We need streamlining the work. Nothing. In fact, it's all gotten worse.
A little different. In emergency room, you either are an hour, kind of a salaried employee or an hourly employee, and they can say, okay, instead of taking care of three critical patients per hour, or you're averaging X number of patients per hour, we're not going to give you any more resources, and now we're going to give you 3 times as many patients. And it all got a lot more complicated, because when I started medicine, we still had T-sheets, which was like a check sheet. The chart's already written for you. You just check the box. Yes, they had this. No, they didn't. Write a couple notes of critical thinking, a plan, and what you're going to do and what their diagnosis is. Now you have to ask them if they feel safe at home, and they've got an ankle sprain, and you need to ask if their mother had high cholesterol. And I'm not kidding. Or the hospital doesn't get to bill at the same level, and they kick it back. And then if the chart gets kicked back, then you're a bad physician because the hospital didn't get reimbursed to maximum capacity. So in the middle of a pandemic, having a cumbersome emergency electronic health record is horrible. They should just cut that out. Go back to clipboards for a little while.
Yeah. Is there anything good about the electronic medical record? I not that I can think of.
One thing is, I did see my physician yesterday, and they were somehow able to pull in my pharmacy records. And they were like, oh, we saw that you were on this medication. I'm like, how did you know that? They said, oh, they pulled it from CVS or whatever. So that's kind of good. Some continuity is good. But in terms of in the middle of, we don't have enough manpower, I can chart way quicker on paper than I ever could on a computer.
Yeah, me too. You mentioned something in your blurb about your background about moral abuse. What were you thinking there?
I just mean that, I grew up, I wanted to be a doctor since I was 9, because I was as sick as a kid, and I thought I'm bright, I'm outgoing. It's a job that I think I could be good at. I could feel satisfied taking care of people. And it's nice sometimes to know that people appreciate what you do. That's not why you do it, but it's nice to feel appreciated. And I think now with online reviews, I've seen reviews of me that were so scathing on Yelp because there wasn't parking in the parking lot.
Right.
Their coffee was Folgers and not whatever. And those have my name on them. And I just don't think that that's the public speaking. So you're getting abused by the public not appreciating that you're working as hard as you can in the system in which you are placed. But they still think that you make $1 million and you work 3 days a week and you drive a Lamborghini. I've got a used Toyota minivan that says otherwise. And $500,000 of student loan debt, right?
Right.
And I gave up all of my 20s and 30s for this.
That's right.
And then now it's worse because some physicians used to have at least they had a shingle to own. They've got a building. They had some skin in the game. Maybe they worked really hard, but they were a partner in a Democratic group and they got some sort of stock options or something. Now,
that has been gone for 20 years.
Yeah, so many of us now work for these corporate medical groups, and we are told every day we are replaceable.
Yeah.
Your job, and also supervise all these nurse practitioners and PAs, but don't see their patients. We don't want to give you enough time to do that. We just want you to sign your name on all their charts and take 100% of the liability for anything they
That's
do.
The part I find incredible.
Don't get sued.
Yeah, I have no problem with supervising NPs and PAs if they remove the liability, but all of it flows up to the physician, and they just ask for more and more supervision. That's literally impossible to do well, literally.
I've gotten charts from people that were discharged 3 days ago that I found medical errors on. What am I supposed to do about it 3 days later? I stay after my shift and call the patient and make sure they're okay and call them back in.
And
right?
Now they're begging us to come back and volunteer in the ERs, which I actually did, and then they stonewalled. It's the weirdest thing I've ever seen. They complain that no staff. I'm here, boss. Let's go. Nothing.
There was a local group that fired 9 physicians in the middle of this pandemic and replaced them with lesser trained individuals. Let's put it that way. And then now, last week, we got an email begging anybody to come out of retirement with any sort of medical license to volunteer to come help out in the middle of pandemic. Why would anybody do that? But in our hearts, we still want to because we're still healers.
Right.
But I'm just saying, I wouldn't tell my kids to be doctors. Would you?
Nope.
I have one. I was thinking it might be if it's a calling.
It wasn't something we planned.
Yeah, if it's a calling, I don't regret having done it ever. I never have regretted it. But it's been very painful a lot of the time. I found other things to do. I'm noticing you're doing a lot of interesting stuff too. And if you're motivated and creative, you can find stuff to do with the training. But the training for me, I cannot imagine having lived my life without that training. But the way
I loved it,
but the way we are treated, people don't understand, and so you either have to be crazy or it has to be a calling, one or the other. So you don't. It's not just something that people could go in because it's a nice career. Might be.
That's okay. I just think people need to recognize, especially the people that are employing us right now in the middle of a pandemic. I mean, that how much mental health problems are out there among the general population right now.
Right.
But there are not even enough psychiatrists are burning out, and we
don't have near enough psychiatrists. Not near.
Right. Well, so who's taking care of the psychiatrists that are burning out? Who's taking care of the other doctors? No. And you can't just produce a psychiatrist. That's a 3 to 4 year residency if you don't do a fellowship. So you're again looking at 11 years. And so after 9/11, we realized how traumatized the police officers were and the firefighters were. This is trauma too. This is PTSD for so many people working on the front lines, not just doctors, nurses, respiratory therapists, environmental services. And I don't think that the government is going to give us the resources and the support that they need. The least they could do is get all the doctors vaccinated that are taking care of patients. It's still not happening.
Certainly over the age of 55.
Especially when you go to the hospital.
Certainly that big group, and that's not a priority group.
Yes, and then you've got people that they work in a hospital and they're having their wife come in and get a vaccine, or their daughter, or whatever, and then they're throwing vaccines away.
LA County's throwing it away. We're going to be talking about that tonight on Fox 11 because LA County throws it away.
They should have a standby list, or they should have all these major hospitals should have people sitting out in their parking lots with numbers on their cars. And when they have to go to throw a vaccine away, if you're sitting there and you're number 1, I don't care what age you are, you were there first, you get a shot. They should never be throwing away vaccine right now if they have somebody willing to give it and somebody willing to get it. That is
it's funny. I'm looking at the thread here, and people seem to be not understanding or in disbelief of the kind of abuse that ER doctors take. Maybe you want to tell them. I mean, is there some stories you could tell without divulging any confidence? I mean, just the kinds of yeah.
Okay, so say somebody has something that's kind of long term, like they've had I don't know, back pain, or let's not say back pain. That's kind of a trigger, but say they've had they've had an ingrown toenail for 6 months. And they're going to be low priority on the list of people to get seen because it's people don't die of ingrown toenails. And
Right.
if you've
got life and death issues that are up the list. Yeah.
So then you go into
there's so many things that go to the ER should never go to the ER. It's just astonishing.
right.
But
Well, but because of EMTALA, because of the government, we can't turn anyone away.
Right.
But medical screening means seeing you and making sure you're not going to die and letting you go. But by the time with an EMR, you take the trouble to see them, take their blood pressure,
electronic medical record,
all that stuff, open the medical record. Yeah, electronic health record. You might as well just finish the visit and see what they need to see. So they come in, so you go to see them and you start to talk to them and you get called into a code because somebody is, say it's COVID, they're dying.
Yeah.
And you're in there for a while and this is somebody's mother who's 52 and you're doing everything that you can. And you're in there for 45 minutes. And now this person had to wait a little bit longer and they're frustrated. And you come back and you've had to wipe your tears away in the parking lot because 52 is younger than your mother. And you go in there and you say, I'm sorry that it took me so long. Let's get back to what we were talking about. And you get yelled at and you get called words that I can't even say on your show because I don't know.
And usually the whole family is there yelling at you with them, right?
Yes. And there's somebody that should have been the system made it to where because they didn't have insurance or because they couldn't get into their primary doctor or because whatever the system is, landed them in an emergency room for something that's not an emergency because they felt they didn't have any other.
Or they didn't. Well, I think the bigger problem, we don't educate people how to use the system. They just don't know that there are telemedicine services and house call services and all kinds of things that are covered by everything that are out there, depending what city you're in. And it's just the ER is the last place you go for general medical care.
Oh, the dumping ground? Is that the phrase you're looking for?
No, it should not be. You should not think of it unless you're essentially ulcerative sensorium, shortness of breath, chest pain. Otherwise,
bleeding to death.
Yeah, bleeding. Otherwise, you should not be going to the ER.
Brain hemorrhage. And
we don't tell people that. They don't know. They don't know.
Back in the day, they knew, and now I think now people use it as it's the only thing I know. And because you're not allowed to say, we're not going to take care of you, you have to see them. And by the time you do all that and work them all up, you might as well just take care of them. So there's been some models that I think have been helpful where some of the private, they're not public hospitals, but they have a triage where somebody decides this goes to the ER or this goes to the urgent care.
But and even urgent care is suboptimal. It's not how.
Hey, look, I see my PCP. I went to the ER for the first 32 years. Right. 32 years I went to the ER. And that was because I had COVID. I was having shortness of breath. I was having chest pain. And I tried my doctor. They wouldn't see me because it hadn't been 2 weeks since my positive test. And they wouldn't even get a lab drawn for me because the lab wouldn't see me if it hadn't been 2 weeks. And so I went to an ER, felt guilty about it.
Yeah.
But
no. I mean,
I'll drop dead of a blood clot before I'll go to the emergency room.
Yeah. I get you.
I felt guilty going to the ER.
I get it. I would feel bad too. I had Susan take me once to the ER because I thought I was dying when I had H1N1. I actually thought I had leptospirosis because I'd been in a leptospirosis outbreak. And imagine you're my ER doctor. I walk in, I go, I've got leptospirosis. When you give me this tetracycline, I'm going to have the Herxheimer reaction, so don't worry. I know it's coming. And she goes, just lie down. Let me work you up. And I was like delirious with fever from H1N1.
I had H1N1 too. You know when I got it? The year that when I was in residency, the year that the vaccine came out, or the year before the vaccine came out.
I was in a residency, but that's the year I got it too.
I couldn't even raise my arms. I couldn't even get out of bed. It was the only time I called out of work ever.
I can tell you H1N1 was more toxicity associated with it than COVID, but the COVID is more relentlessness. It's just relentless symptoms. Just keep going. It's just, ugh.
Are you having problems with your days and nights being all screwed up? Because that's where
everything's all screwed up. I'm emotionally screwed up. My sleep screwed up. My breathing screwed up. My cognition is screwed up.
Mine is too, though.
That's because I'm probably tossing and turning during the night. But I want to
just go by. It's weird.
Yeah, but I guess the question I have before I want to get into all that sexual health stuff you're doing, Emily. But the question I have is something wrong with our profession right now? When I see all the rhetoric that people are getting into on Twitter and the infighting, and I've never seen anything like this where have an opinion about a medication or a treatment is somehow political in medicine. That's the weirdest thing in the world to me. And it's one thing to have strong opinions about certain therapeutic interventions, but to condemn a person or to prevent that person, another doctor, from practicing their medicine the way their judgment tells them to practice it, I've never seen anything like that.
I think you have to realize that we're taught that everything goes back to evidence-based medicine, and that the gold standard is double-blinded, randomized controlled studies.
Dr. Porter, we all know that evidence-based medicine is flawed, and it has to be reproduced many, 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 many times. I will just point you didn't live through this. I lived through the Women's Health Initiative, which now you're doing BioT, which is hormone replacement therapy. We were told if you did hormone replacement therapy, you were no better than a witch doctor. Literally, those were the words in the New England Journal, one publication, because we now have the gold standard study, the Women's Health Initiative, tens of thousands of women, multiple countries involved, and it was flawed. The assumptions were all flawed. The setup was flawed. It was a completely worthless, not completely, but mostly worthless study. And all of us in primary care started taking women off hormones, and the number of hip fractures and dementia and atrophic vaginitis and dyspareunia just went off the chart. Women were harmed by that evidence-based medicine. So you don't have to go through too many of those before you start wanting things to be reproduced many times. And by the way, personally, I've done this for 35 years. When my clinical sense is that there's something wrong with the evidence-based material, I'm going to stay with my clinical judgment.
Yeah, and you have the right to do that. I agree. I mean, I would say there is a lot of fighting within specialties. There's a lot of turf battles, and I'm going to postulate here. I don't know that I'm 100% correct, but I feel like there's more fighting within among ourselves, because we feel threatened by the outside, right? So when you feel like you're not being respected by your corporate medical group, or your job is threatened by non-physician practitioners that you're told replaceable, or you're whatever, instead of it's easier to fight with one another on Twitter or whatever, or to say that somebody's only doing something because it's cash based. I mean, I had a guy call me the other day for some medical advice and tried to sell me on a multi-level marketing gig. And
a peer?
Yeah.
Oh, geez.
And he's a gynecologist in his late 50s, but he's so strapped for feeling like he can't get out from his debt, from his whatever, his loans, and feels like he could never retire. How am I going to judge him for that? I didn't do it. I don't, but I felt bad that he ever was in that position. But then you have this cognitive dissonance where the public still perceives, now we're the enemy. Now rather than fight with the public, rather than fight with the people that are making us feel this way, we fight with each other because it's easier. So if you're not a dermatologist and you inject Botox, then it's a turf war. It's stay in your
and to be fair, we are, I don't know what residency was like when you were in, but it was a pretty abusive experience. Mostly, and then what did you do to the ER residents when you were a senior resident? I mean,
you abuse them. That's the way you learn.
You reap as you sow.
So I'm going to treat you that way. And they made it better. They made it less abusive. They cut the hours from 80 hours a week to 60.
I think that was a huge mistake, by the way.
And they said that they can't work more than we used to work 24, and then you got 6 hours of cleanup. And now I think they limit it to 12 or 18 hours or something like that. But you just said it's a huge mistake. But when they try to not abuse people as much, it's a mistake. You see how you can't win?
I know. I understand.
You can't win. You can't win, and I can't win, and they can't win.
Well, whenever you have forces from outside the profession demanding and making the decisions for us, do attorneys allow people to determine how attorneys are trained? Are you kidding? Or what they can do with their scope of practice? Are you kidding me?
No, well, you have the government. It's the government. So we have a physician shortage. I call bullshit. We have a trained physician shortage. They graduated almost 4,000 physicians last year in America that did not match in residency. Why? Because the ACGME, the US government controlled by Medicare and Medicaid, has not increased the number of residency positions to match the growing need of the aging population in this country. And corporate medical groups said, we can get them faster. We'll produce online degrees for non-physician practitioners who, don't get me wrong, there's lots of love and lots of
me too.
Room in the world for all types of medical
providers. 100%.
But they're not the same. And then because if they are the same, then I want my money back.
Yeah, me too.
I want my 20s back in my
30s. Yeah, I want the decade of my 20s, and I want about $1 million of educational expenses back.
Right. So they either are the same or they're not. And so, and if they are, then why do I still have to do all my maintenance of certification and my board?
Which always gets worse, which always gets more and more and more with time, which is even more astonishing.
And so, you talked about telemedicine. My stepfather had pneumonia during this whole Christmas. After Christmas, we didn't see anybody over Christmas. We never planned to, but I'm glad we didn't because we all ended up having COVID. But he got pneumonia, needed to be admitted to the hospital. He's got COPD from smoking in Vietnam. So they didn't have room in the hospital because of COVID. So they said, it's okay, we'll send you home, and we'll send you home with some oxygen. He's never been on oxygen before, and some oral antibiotics, and we'll have you follow up.
Right.
In my day and in your day, that follow-up would be 48 hours. He'd see a doctor again. He'd have somebody listen to his lungs, maybe get a chest x-ray a week later, see how he's doing. They sent him home with no pulse oximeter, so he has no idea whether the oxygen's actually doing anything other than making him feel better. Follow up with telemedicine with a pulmonologist. How is a pulmonologist going to listen to your lungs doing what you and I are doing right now?
Right. And now that pulmonologists, they're not geared up to do that kind of outpatient assessment. They are ICU doctors, essentially.
Right. And so not all care is the same. And you can't some of those things are great. Let's sub in this, let's sub in that, and call in everything that we have. I admit, but he would have been better off finding a family practice physician who had an opening in their schedule, who could have seen him and listened to him.
Of course. And by the way, there is a place for a nurse practitioner or PA in that role right there. If it can be properly managed.
Okay, that would be great.
Absolutely.
So, and I couldn't see him because I didn't want to give him COVID, right? And so then you got the government reporting statistics saying hospital admissions are down or they haven't increased. Well, yeah, they did, because he got admitted to his own house. He should have been admitted to the hospital, but because they didn't have any room or they had sicker people, they sent him home. And so the public looks and says, well, it's not as bad as what everybody says because the numbers aren't there.
Crazy. I wish we talked more about morbidity too with this thing. I think there's such a focus on mortality, and the morbidity is profound in terms of, particularly in the risk populations like myself, in terms of the misery of the illness, the injury that we suffer. Are you back in the ER now? Or are you out? You back in?
No, my husband's back too.
Okay. And are you seeing post-COVIDs come back around? Not really.
It's not sick. It's not that sick. It's
what I was going to ask you is if you'd seen a post-COVID chest x-rays, because there was a trauma surgeon that went public today and said all her COVID patients have severe scarring, interstitial fibrosis or something. And I was like, I don't know about that. That doesn't seem right to me.
I have a friend who got COVID in New York City. He's a physician in New York City. He got it in March, and all of his scans look normal, but he can't talk at all the way we're talking or walk across the street without getting out of breath. And he was a healthy 40-something-year-old guy, and he's not back to his normal life. And that's been 10 months?
Sheesh, awful. Whew.
My grandmother passed of COVID over Christmas or the 14th of December in a nursing home. And, so there's a whole, how did that get political? So she's 94, but she didn't die of something else. She died of COVID. She got COVID. COVID made her not want to eat and drink. So she went into renal failure, because you're not going to put a 94-year-old on dialysis.
Right.
But we didn't. And she died. So she wouldn't have died if but for COVID, or right?
Right. And at least not maybe been within the next 12 months rather than.
Right. Or whatever. She could have died of something else, but she didn't. But now you have people telling me that my grandmother's that it's a lie, that somebody got paid to write COVID on her death certificate.
Oh,
So you're
yeah.
not,
I hear that stuff all the time too. Yeah,
or that a doctor got paid more to do that.
Yeah,
That's another form of
I
abuse.
think what
right?
you should tell them is the hospitals, as a convention, hospitals agreed they would be liberal with the definition of comorbidity of COVID because they were closing down to everything else. So they needed to be able to be reimbursed for COVID at a higher rate in order to keep the doors open. So that was the hospital deal early on in this pandemic, and it was the right thing to do. It was just the right thing to do.
I'll challenge you this without knowing your medical history.
Yeah.
If you had COVID and if you drop dead in another 2 weeks,
Yeah.
and say you had a heart attack or a pulmonary embolism or a stroke,
COVID.
assuming you had a clean medical history,
COVID.
would you not say it's COVID? Because I would say
Absolutely. I would say, again, our death certificates are so messed up. I don't know if you have to fill those out. I fill them all the time.
Oh, I fill them out all the time.
Yeah,
I know how to.
But it's messed up. It's, there's proximate cause, pulmonary embolus, cardiopulmonary arrest, pulmonary embolus, and then ancillary causes. And the COVID would go in the ancillary, I guess, or you could flip it around and put the COVID number 1 and put the pulmonary embolus number 2. There's no regulation around that stuff.
I think, and that you have to put something, and you can't put cardiac arrest because that is death, or respiratory arrest. You have to put due to something. But I think what people don't understand is that if you get shot when you're 20 and you don't die, but you become a paraplegic and you have to self-cath, because your bladder doesn't work right.
Yep.
And then now you end up dying 20 years later of a multi-drug resistant urinary tract infection because of overprescribed antibiotics, because we're pressured to give everyone an antibiotic, because when your copay is $500 and you came to the ER, you don't leave for a virus without an antibiotic, or you're going to write a negative Google review. You see what I'm saying? And then if the Google reviews are too bad, then the hospital doesn't get paid the same amount of money. So it's bad medicine all the way around. But if that person dies 30 years later and they wouldn't have died otherwise, and that gunshot wound is the thing that started the cascade, that can be considered manslaughter or murder.
Oh, interesting. Somebody asked a question. I'm going to have you answer it. Why don't hospitals hire more doctors?
Why don't they hire more doctors? They have to have trained doctors.
Well, no, but he's saying you need more doctors? Hire more doctors. They're doing the opposite. They're
getting rid of doctors now because they can pay people who don't have MDs, 75% as much or half as much.
Can do a lot of the grunt work and then have a fewer number of doctors take all of the liability. Not the hospital,
in most states,
the doctor.
Still all the liability.
Yeah.
In most states, it's still all the liability.
It's
and
crazy.
so that's the problem. A lot of physicians are retiring early because they don't want to lose their house or to lose anything that they have left, because I can take responsibility for my own actions. And I worked as a teaching attending for a while, and I felt okay having a resident go in and see a patient, and they would talk to me about the patient. I would go in, brief, quickly go over everything with the patient again, put hands and eyes on them, and then feel comfortable because I saw the patient. So I can take that liability because Medicare won't reimburse unless the attending physician saw the patient. But that's not how it works with non-physician providers. They're on their own doing their own thing. And you sign a chart a day later or 2 days later, and you don't want to lose everything over that. I don't.
So I taught in several different settings. I taught general medicine. I taught adolescent medicine. I taught addiction medicine through psychiatry. So I had 3 different clinical professorships that I taught over the years. And there was, so when I was training residents, there was a couple of absolute rules in my own mind, and I made it clear to the residents in whatever setting I was working with them, that there are 2 things that drove me crazy. And you tell me if you agree with me on this. One was, make your decision. Don't be afraid to make your decision. Make sure it's a good decision based on evidence basis. I want to see the evidence. I'll assess whether the evidence is, something we can rely on or not. But you're a resident. You just show me the literature that backs up your decision making. If you're wrong, or if it doesn't work, you better have a backup plan. I want to know what your backup plan. If you have no backup plan, I'm going to be very angry. So I was always wanting people to play chess a little bit, to be able to think through what they would do if their decision making didn't go the right direction. And what I would usually get back, and this is the point of my little story here, is something on the order of, when I ask, why did you, given that that antibiotic failed, why did you, intubate the patient at that point? Oftentimes I would get back, well, I had to do something. And I feel like I had to do something is one of the most dangerous statements I hear doctors make. That's called iatrogenesis. It's how we hurt patients. And I'm hearing we have to do something all the time from the public health officials now. What do you say?
What do you think the public health officials think we have to do?
Lockdown or something. We have to always do something. We have to do something, even though there's no evidence base for it. We don't know what we're doing. I got into it with the California state officials, and I was like, why the outdoor dining? There's been zero transmission. What's the evidence? We had to do something. That was their defense.
So, okay, we can do a had to do something case then, if you want to play
Sure.
that game. I love this game. Okay.
Sure.
So guy on a plane flying back. It was about a month or two ago. So pardon me, I don't remember from where to where, but it was a long way. And he crashes and burns, 20 minutes into the flight, and is having respiratory failure. And so they're on the plane. And so somebody feels like they have to do something. Then I guess they start doing CPR, right? How are you going to save somebody on plane? It's very hard. You don't have the equipment. You don't have a ventilator. Even if I could intubate somebody on the plane, I got to be able to give them breath.
But you can give them positive pressure. You can breathe for them.
You can do something, right?
Yeah.
But are you going to do something, or are you going to sit and watch this man die? Well, it turns out when they had tested positive for COVID.
Right.
And they got on the plane anyway. And now they're doing CPR and aerosolizing COVID all over the plane.
Yeah.
And you've got physicians and doctors who would sit in their seats and watch this man die after taking an oath because of worry about life.
That's not, they all actually know the people involved in that. And interestingly, the main guy was an EMT, and he did not get COVID, strangely enough.
Well, that's amazing.
It's amazing. And
they
they were not doing but the point is, they were not just doing something. They were doing something they were trained to do when somebody was in respiratory distress. There's loads of evidence for how you do advanced cardiac life support and when you do it. Tons of evidence for that. I'm saying occasionally you'll see a physician just say, just like I just randomly selected something to do without any evidence for it or any training in doing it because I felt I had to do something. And that gets problematic. I had to do something because you end up doing more harm than good. That's all I'm saying.
Says that you can do whatever you want. The question is, will you still have your peers judging you? Your medical board is made up of your peers.
Yeah.
And so you can do as a physician, you can do anything that your license permits you to do, whether that be an experimental therapy or whatever. But there's a risk associated. And part of that, unfortunately, now has been us eating each other. I mean, like in terms of criticizing each other for therapies. I get asked all the time about ivermectin, and it's hard because it's like, right, you want to do something. If you get COVID, did you take ivermectin?
I did. There's tons of evidence for it. Tons. I reviewed the literature. Overwhelming evidence for it.
Did you take hydroxychloroquine?
I didn't want to take hydroxychloroquine. Somebody convinced me to do it, but I was not convinced by the evidence of that. Because
some of the evidence, right? So is that hydroxychloroquine might make things worse, but I haven't, people haven't.
In the hospital though, not out. I was an outpatient.
The same. So I think right now with all of COVID, the whole thing being the shit show that it is everybody's feeling like, I want to help, put me in, coach.
Yeah.
But I don't want to do something that's going to cost me my job.
Yep. That's right.
But I don't want to sit back and watch people die because I do want to help people and I am a good person. But tell me what to do. And then who's directing everybody?
Well, again, there is evidence. There's tons of evidence for it. This is not random action. This is based on the literature that's available worldwide.
But when you have a corporate medical group necessarily, you don't have the autonomy that you had when you had your own practice. What you can do in your little wooden sign outside of Dr. Drew's clinic is different than what Dr. Drew, who is an employee of this major health group,
I get it. I understand what you're saying.
We know that.
Yeah. Well, speaking of doing other stuff, let's talk about your sexual health stuff. Where do you want to start with that? Because the BioT, we're big. My wife is a bioidentical hormone patient, and it changed her life. We've seen
I'm a pioneer.
Many people's lives changed by that. And I see you have a lot of other stuff going on here, including GainsWave, which is something that I had supported for a while. It seemed like a non-nice invasive way to treat ED. Where do you want to start this story?
Oh, just, I started doing other stuff to have something else in my life where I got to have happy patients. And really, I got to have control over the patient outcome, right? So I started doing some things outside of the emergency room while still being an emergency room doctor. And I've loved it. It's made me a better mom and a better wife and a happier person to be able to go and do some other things while still doing those things. And I didn't do them without having any training, and I didn't do things that I thought in any way could hurt anybody. And I needed the evidence, like you said. And but I've had way more, this is sad, I've had way more job satisfaction in the last 4 years or so, 3 years or so of my life doing these things that are not life-saving procedures than I ever had saving people's lives in the literal sense.
Yes, I have experienced the same thing. But curious on a couple of things. Again, back to the bioidentical hormone replacement therapies. It's controversial. I've just seen just irrefutable evidence that there's so many reasons why it's a good thing for some people, given the properly selected patients and then properly monitored. But there are still doctors that will cling to some of the older data that say, "Oh no, you're giving people cancer."
Well, the problem is you referenced the Women's Health Initiative back in, what was that, 2001?
Yeah.
And so I trained, it was, you don't ever give a woman, I don't care if she's 35 and has to have her ovaries taken out. You
That's
put
right.
her in a hard and fast menopause.
Yep.
And she'll just have to deal with it.
Yep.
And you have to bleed every time her husband wants to be intimate, because that's just how it is, because heaven forbid she gets cancer.
Yep.
Drew, there are people who would, if you told them they had a 20% chance of getting cancer in their lifetime from getting hormones, they would take that chance. Because they don't want to live the way they are.
And bone fragility, mood disturbances, cognitive issues, all that is enhanced with some women given hormone replacement.
So why have they not repeated the Women's Health Initiative? The women were in their 70s. They were 20 some years past menopause. They gave them synthetic hormones.
Yep.
And then they said some women died, and the women died of things that 79-year-old women die of anyway.
And we know now that co-prescribing testosterone may actually reduce the risk of breast cancer.
Right, and reduce the risk of prostate cancer and things like that. But where's the money? That's the system that we're in right now. You have to have another big company willing to fund a study, get the institutional review board and involve the IRB, fund it. You have to pay the patients. You have to have patients willing to trust the doctors. To get FDA approval and all that stuff. So what company is willing to do that? Right now, it's nobody.
Yeah, I agree. But one of the things I'm surprised you're getting involved with is some of this urological stuff. What is priapus? Is that if you get priapism?
Yeah, no. So it's a Greek, I think it's a Greek god of fertility. So how they talked about convalescent plasma during the whole COVID thing?
Yeah.
I'm a huge fan of plasma, of platelet-rich plasma.
Okay, okay.
And so there are some therapies that you can do for wound healing, where you either it started out where somebody would have a wound that wasn't healing, and you can take their blood, spin it down using some FDA approved kits, get the plasma that has lots of growth factors, where you put them back into the body, and they sort of simulate a wound, and then they cause all the stem cells to be recruited and all the wound healing things. I'm not going to say all the big words, but EGF1 and all those things.
Right.
And so you have wound healing, and you can take things better than what they were. And so you can use those. It comes from the person's own body, put back into the person's own body, almost like an autologous blood transfusion, like they did in Ghana when I lived down there. Take the blood out, do something to it, put it back. And so we've had a lot of success with that. On women for sexuality, men for sexuality, scar healing. I've had people that had some non-healing abscesses that we've injected it into, and the risk is very low.
When you say men and women for sexuality, what specifically?
Oh, well, so if women have stress incontinence.
Okay.
So they sneeze when they urinate when they sneeze. So they're not bad enough to go have a whole surgery. and they don't want to go have a huge expensive surgery, but you can painlessly inject some plasma, like a couple, less than a teaspoon of plasma, into the area underneath their urethra, and cause collagen to grow. And then when they sneeze, they don't wet their pants. And then there's studies in Menopause Journal about lubrication. So some women have had cancer, they don't want to have hormone replacement because they're worried about the estrogen, but they're so dry. So they need a non-hormonal way to increase lubrication. You can inject platelet-rich plasma into those areas, and it will stimulate the glands to produce more lubrication. Or men for erectile dysfunction, or men for priapism when they have an abnormal curvature of the
Peyronie's.
I'm sorry, Peyronie's. It's a private shop for Peyronie's, yeah.
That's what I was wondering, if it was something we'd use for Peyronie's. That's interesting. It makes sense to me.
Hey, Drew.
Yeah.
Dr. Yo is here. He wants to do a quick little plug for his new website.
Bring him in. Sorry,
hey, Dr. Yo.
Dr. Emily Porter is Dr. Yo.
Hi, Dr. Yo.
Dr. Yo, where are you?
Hi, Dr. Porter.
Hey, buddy.
Dr. Drew.
So congratulations on the new website.
Yes, thank you. Yeah, it's been several weeks of putting this together. It's a lot of regulatory and sort of legal things we have to put, considering with having patient data and HIPAA stuff.
And so who do you want to show up, and under what conditions?
Well, we're looking at the chronic COVID patients, also known as the long haulers. And, the British Medical Journal is defining long COVID as 3 weeks after the onset of symptoms.
Oh, well, I'm there.
Chronic.
I'm there.
Right. I think you might fall. I think a lot of patients are going to fall under long COVID. It doesn't necessarily mean we have to start treatment, but that's sort of that definition they're putting. And chronic COVID is 3 months or 12 weeks after the onset of symptoms, which we're dealing with a large cohort of these patients. And I think that's the group we're really targeting in terms of the blood testing and the treatment. So we got the chronic COVID.
Yeah.
I mean, we're still also the long COVID. We like to kind of, like with all phases of COVID, it's early and aggressive treatment. And I think it's the same thing for these chronic patients or these long haulers. Immediately, as long as we can start addressing some of those issues, I think that's going to be key, because some of these patients are 11, 12 months after infection, and they're still having some really severe symptoms. And if we start dealing with the mental health aspects and the psych issues now, these people are just downtrodden and feel hopeless, and they're just clinging on to anything, which is also, one of the reasons why we wanted to get the website and get some of these other resources out there. Is there's a lot of really bad information and a lot of characters that are posting things that quite frankly could be potentially harmful. People suggesting getting these medications, unregulated medications from overseas that are not available in the United States. People having all sorts of theories and trying things out. So I think we have to be really careful that we have to have, we are in a new, sort of going in a new direction, and this is some new science, but we can still do this under safe and, not risky treatments. And that's the one thing I'm really, really concerned about being on social media. I see all sorts of treatments that I'm just wondering, it's downright scary.
What do they talk? Like what?
People, obviously the issue with ivermectin, and because some prescribers are very afraid or feel like there's not enough data, a lot of patients are getting horse paste and animal ivermectin and cutting up the doses. And, so they'll ask me, Dr. Yo, what's the dose of it? And I don't ever post doses for that very reason, because I get a feeling that some of them are getting it from, they're lying to the veterinarian, the vets, and getting it from, I think, Amazon. You can get horse paste. And that was obviously the concern of the FDA in the first place, was when they put out that their advisory against the use of animal ivermectin back in April. It was for this very reason.
Wow.
And then people are getting it from, there's these online pharmacies. They don't even have a website. You contact some guys on WhatsApp. I'm not even making this up.
Oh my God.
You contact them on WhatsApp, and they will send you. You pay them on PayPal, and then they send you ivermectin. They claim to give you ivermectin. And so these are some of the things I'm really, really concerned about with the medical community, because, but at the same time, I understand where these patients are coming from.
They're desperate.
They are desperate.
Yeah.
And how do you tell someone, well, when they tell me I'm taking animal ivermectin, it's the only thing that's making me functional. How do I tell them to say, no, don't take it? I mean, it's kind of like, well, I don't want you to take it because I don't know if you're really getting,
Right.
if it's safe,
Right.
and if you're even really taking ivermectin. But at the same time, how do you tell someone that to go and suffer? And it's really tough dealing with this cohort of patients. But we're really excited about the website.
I keep hearing weird stuff about ozone therapies and all kinds of what
I grew up on a farm, so I'm well versed in ivermectin, and also 40 years ago, people who didn't have insurance, who weren't poor enough for Medicaid, who would go get clindamycin from the vet. You don't even need a prescription for ivermectin if you can go to the Tractor Supply Company and get it.
Oh wow!
You don't need to get it from a vet friend.
That is crazy. But what about the ozone therapy, yo?
It's funny you mentioned that. There was actually a lady in England while I was at work today. She texted me. She's taking her daughter for ozone therapy and it's not working. Some other patients are doing hyperbaric chambers. I couldn't even imagine what the cost of that is, but that's not working. There are people claiming, and I think just for overall everything with COVID, there's no magic pill. I think it's a heterogeneous disease or virus. Everyone has a different response, and this whole thing like, oh, take niacin. Now that's a big thing for a while. Take niacin. No, there's some patients they did have some benefit with niacin, but there's a lot that didn't. Or take ivermectin. Ivermectin is the cure for everything. It's like, well, no, actually, I do know patients that took ivermectin and they didn't touch them, the long haulers. And histamine. I mean, all sorts of things. So the key is to find out what exactly works, and what Dr. Patterson and I are looking at is different sort of finding patterns in the immunology, and from that developing algorithms for treatment based on the immunology. For example, if someone is responding to ivermectin, well, is there something in their immunology that is, it's why it's working, or if there's something in the immunology that's going to suggest that they're not going to respond to ivermectin. So we're able to develop very diagnostic and very precise medications and treatments based on their blood work.
My husband took antidepressant. He's in a randomized controlled trial
for Luvox.
Mm-hmm. He thinks he's a toxicologist, so he's pretty sure he got the placebo. But
so it's 100 milligrams 3 times a day of fluvoxamine. How about that one, Dr. Yogendra?
Yeah, there is. There's some of these anti-psych meds that could potentially have a role. I think it's very interesting because some of them they work on the cytokine system and act in the pro-inflammatory cytokines. It's into the literature because we use them in fibromyalgia, chronic fatigue. So we have to test and see the response.
Well, I'm hoping that I keep moving forward, but I guess I'm 3 weeks today and I'm not exactly good. So if you want my blood, or let me be a part of it.
My son got really depressed too, even though he kind of flew through it.
Oh yeah, this thing has psychiatric effects for sure. I had OCD and a lot of just weird
and COVID don't
ruminating
mix.
And stuff. Yeah, irritability and jumpiness and stuff. I jump at people. Yeah, do you want blood?
Sure. I'll send you the protocol. I'll email it to you. We'll take everyone's blood. We're like vampires now.
All right, fair enough. All right, well, thank you for stopping by. The website is covidlonghaulers.com. Anything else? Anything new?
One thing before Ram goes, we had a question from Joe Giannotti on my text. He said, ask you about the NIH report about ivermectin.
NIH or WHO, World Health Organization?
NIH.
Yeah, I think there's something. I haven't gone through all the details. I skimmed over it. I know the NIH, they're not saying no to the use of ivermectin. I don't think they've come out and said yes, this is the drug, but they're not saying no to it. So I have to go and read a little bit more about the NIH. But there's a lot of data that's coming out, the use of ivermectin in active COVID. So I've been prescribing it. I've seen some incredible results. With a lot of patients.
What about late use of steroids?
So the recovery trial in the UK suggested in the critical COVID patients, it had the most benefit. So I think there is a role. I think that's become the standard of care in a lot of the ICUs.
No, I mean for
steroids.
a second round for the long haulers.
We are trying that. So some of the patients, we're actually doing different combinations. It's either Maravirac and steroids, Ivermectin and steroids. The thing is, none of the patients so far, with Ivermectin alone, there's a reduction in their symptoms, but it doesn't take them out of the sort of the long hauler category. So I think there's some other either a combination or a follow-up medication that gets them out and sort of resolves their long hauler symptoms. And what that is, it's work in progress.
Are you any sense that there's continued activity in the lungs?
Quite. It's interesting you say that. There's one patient we're dealing with. This 10 months out, we can't figure out. She's a healthy 43-year-old. We can't figure out. She's got all these respiratory problems, and we had her. She got a CAT scan. She had a cardiac cath. She had an echo. We've done the full cardiac respiratory workup, and nothing. She's had a bronch, and she has difficulty breathing. She's always tachypnic. Can't figure out the reason.
Emily Porter has a friend like that too, right? Your buddy.
Yeah, he still can't have a conversation or like talk and walk across the street and be on his phone. It's too much. And he got it in March 21st, and no medical history, and pulmonologists can't find anything.
Crazy, right?
And a weird neuropathy. He said he has like this weird neuropathy where everything feels numb until you touch it on his legs, and then it's a searing pain that nothing is making.
Yeah, well, that's sensory neuropathy. Oof.
So it's interesting you mentioned about Dr. Porter about the neuropathy and the burning sensation. We're starting to think it's most likely due to VEGF, vascular endothelial growth factor, which are elevated in many of these long haulers. Again, with the cytokines, it's very difficult to point out, well, this is the one, this is the causative reason. But some of the data we're getting now is sort of saying that possibly the VEGF is playing a much bigger role in the neuroinflammation and some of the vasculitis. And it correlates with what we see in the literature. So interesting. But interestingly enough, ivermectin doesn't do anything to VEGF. It's bringing down interleukin 6, and I believe interleukin 2 and interferon gamma levels within 24 hours. That's
are you just very
thing.
quick before that? Where do you fall on the tocilizumab for the sick patients?
Yeah, that's an interesting. I think that there's a new study that came out, published in the New England Journal.
Yeah, I saw that.
It was tocilizumab, IL-6 receptor antagonist.
Yep.
It makes sense, but here's the thing. Again, everything is about giving these medications timely, and not everyone's going to respond to it. It's the same thing with ivermectin, leronlimab, all of this. There's not like one cytokine that's elevated. I mean, a lot of patients have elevated in RANTES, but some have GM-CSF. They're really sick patients that don't even have elevated interleukin 6 levels. So how do you explain all of that? So I think this is where Dr. Patterson's saying, the specific treatment based on the cytokine profile, and we target that. So I think some patients could respond. But the other thing that really concerns me about tocilizumab and saralimab is there's a liver issue with that.
And there were some studies where it did not look good. A bunch of studies early. So
some of the early studies are
antibodies into people though. We're talking about vaccine distribution. We have all these monoclonal antibodies that are sitting, and there's no staff to put them in.
Yes,
it's a 1 hour infusion. It's a 1 hour infusion with a saline flush afterward.
Yes,
and
I got
bamlanivimab.
I got bamlanivimab, and it stopped it really helped me. It kept me from being in the hospital, frankly.
What day of your illness did you get it?
I got sick on Thursday. I got it on a Wednesday.
So 6. So we try to get for my husband, and by the time they could get him in, it was more than the 10 days. So you can't get any.
And I've been pushing that ever since I got it. And you would be astonished how many physicians either say that's a hospital medicine or no, you can't get that. And it's covered by everything. The Secretary Azar of the Health and Human Services.
But it's free. The government paid for the medicine, so it's sitting there rotting on a shelf.
Yes, he said, please take it. Azar used to run Lilly. He understands pharmacology, and he's like, we have it sitting there. You can get it. Just have your doctor sign up. It's distributable. It's really
the ER where I trained in New York is giving it in the ER. They're giving Regeneron's product, and
why
they're
not? Why
you
aren't
like
more
in
doctors?
because they're like you come in, if you're sick, not sick enough to be admitted, but you fit the criteria, they give it to you right then and there and send you on their way.
They should be doing that everywhere. I completely.
They're not.
That's good news. That is good news.
He saw the light. He was like, the light's at the end of the tunnel after that one.
Yeah, I was stronger
The
after that.
Ivermectin made him feel better too.
But the Ivermectin, I wish I'd taken it 5 days, Dr. Yogendra. I took it 1 and 3, and I think I should have taken it 5.
So as a layperson, and like I don't get sick very often.
Ever.
It seemed like Drew was taking a lot of medicine all at the same time, which worried me. And you were taking 3 or 4 things at the same time.
3, I took like 12 at the same time.
Yeah,
okay.
I'm hypertensive.
Okay.
I was taking I certainly didn't want to not take my cholesterol meds. That might be part of the whole clotting problem. Yeah.
Melatonin, aspirin. Yeah, I had it all.
Well, he had the antibiotic, and then he had the steroid, and then he had the ivermectin, and then he had the hydroxychloroquine, and then he had the dexamethasone in the. I mean, I was like, wow, that's a lot of stuff. But I wonder if recovery is a little slower because of all of that.
Well, Dr. Yogendra, that is something that Bruce Patterson believes.
Yeah, I think everything is about timing of medications, and Dr. Patterson believes we're creating long haulers with the use of steroids. I think his thing is we are. I
got to tell you, here's the clinical diathesis in this. If I hadn't taken the steroids, I would have gone to the hospital. If I'd gone to the hospital, I would have been a bad stat. The stats wouldn't have gone. You know what I mean? My stats would have changed. And so Decadron kept me out of the hospital. I'm okay with if it lengthens the recovery period, right?
Again, some patients. I think giving it early doesn't hurt, but I think there's some validity to what Dr. Patterson's saying. But here's the interesting thing: you got steroids with a monoclonal antibody and ivermectin. What happens if we're just giving steroids alone to patients?
No.
Could that potentially be? Should it be an antiviral with a steroid? But the steroid is working on the inflammatory processes taking place, and you need that antiviral. I mean, part of the treatment we're giving patients is we're telling them go home, drink fluids, and take Tylenol. But if we're creating long haulers, or where their symptoms are continuous, then perhaps we should consider these ivermectins and monoclonal antibodies. But so many healthcare providers don't know about these monoclonal antibodies. My friend in Missouri.
That's bad. That's a scandal, frankly.
When remdesivir only decreased, it didn't decrease mortality at all. It decreased length of hospital stay by 2 days. So that's the best we've got. I don't even know what the best we have is right now. I don't think there's not really any strong evidence for monoclonal antibodies in terms of the evidence that doctors want. That I've heard. Anecdotal, but not anything on hard and fast on paper. So I don't think, to be honest, any of us know what the heck we're doing yet, and it's 11 months into the.
That's a great point. So the question then becomes: do you mandate hyper conservative or hyper aggressive approaches, or do you let doctors use their judgment, as we have always done throughout the history of medicine? It's so weird to me to think that we're mandating one approach or the other.
You can read the studies, and I think you still have to have physician autonomy, but you have to juxtapose it with patient autonomy, and there has to be a balance there, because when you're talking about I'm joking about taking 12 medications together. I'm certainly not advocating polypharmacy, but I'm married to a toxicologist, a medical toxicologist. So I know that the drugs that I took together didn't interact. I certainly wouldn't want to throw that out there to the world and say everybody should be taking Tractor Supply Company ivermectin along with hydroxychloroquine and their whatever. I don't know what they're on at home, right? I know that what I took was safe and could do no harm to myself. But you also have to not do harm to patients. I think that's where we are. That's where, when you have a one one size fits all approach, it can actually be more harmful for the patient, because circling back from ER, their person's primary care doctor knows them better than anyone else. And they're the least likely to get sued because they have a relationship with them. And if that person were my patient and I was their PCP and they wanted me to try the ivermectin and I read the studies and I thought it couldn't hurt them and it may help, I would probably do it.
Of course. I agree with you. Everything you said, I agree with. Dr. Yogendra, want to wrap up?
No, I actually agree with Dr. Porter 100%. And, I think we have to start getting this. It's all about getting information out. End of the day, getting information out, letting our physician colleagues know, look, we can sit there and tweet about it and talk about it, but talking to other physicians out there, look, there are these monoclonal antibodies. Look, there's the leronlimab. People don't know the difference between leronlimab, the class of antibody, monoclonal antibodies, and bamlanivimab, whatever.
Those are one is a, and let me just, now that you brought it up, so one is a monoclonal antibody that is directed at the spike protein of the virus. Another is the leronlimab is directed at part of the inflammatory, directed at suppressing the piece of the inflammatory cascade.
And the number of critical care docs I've talked to, that is just like, I would bring up a leronlimab and they would say, well, that's for hospitalized. I heard that's for non-hospitalized patients, or
leronlimab?
There's so many side. Right. And because they were getting confused about what the monoclonal antibodies are. If they're confused about the class of medications when to give it, I mean, how can you have a conversation about
that? Well, I asked Emily, Dr. Porter, the same question. I'm going to ask you again. What's happening with our profession? I was like, because Emily is very loud online. She speaks out. She speaks her mind, and I enjoy it. That's why I brought her in. But part of it was sort of questioning how the profession is being treated and how we treat ourselves. You want to ring in on this?
Well, I think let's put it this way, Dr. Drew. Look at your Twitter feed. Look at some of the awful comments people have to make to you.
Yeah.
And then look at Susan's, and look at a lot of the doctors, like Dr. Zelenko. Good God, I think he's still suspended from Twitter. Yes. We've created this culture where doctors are afraid. We're afraid to be physicians, and we're relegated to being technicians, where we're we're not using our judgment and our clinical skills, and we're afraid. If I talk about ivermectin, I've got friends of mine that are like, well, I can't really bring it up in the hospital because some administrator or some hospital system. Now I can freely talk because, just because the nature of what I do, doing per diem and locum work. But I think we've created this culture where there's departments and administrators and regional directors that are really controlling clinical medicine. And unfortunately, people are afraid to talk. People are afraid to look at the information. And there's so much of information out there. Who is telling us the right thing? I mean, talking about long haulers, there are some doctors out there that are, I see some of the messages. I'm going like, my God, that doesn't make any sense. And so there's a lot of, and the clinicians don't know what are some of these really interesting research out there. I always say that there's a massive disconnect between the research world and the clinical world. The researchers are publishing the papers, patting themselves on the back, saying, great job, great papers. And clinicians don't know what's out there. They're waiting for the CBS report, right, or some with the mainstream media coming and talking about.
In defense of physicians, you can't go to educational continuing medical education conferences right now. You are so slammed that you don't even have a freaking physician lounge anymore to have lunch provided for you to discuss, hey, did you read that thing about ivermectin? You're counting on people doing what we all do, which is reading our Twitter at 3:00 in the morning when we can't sleep. And so that's a lot of where you're getting your information. And then you're being told that because nobody's got time to check their email. And then the hospital on a good day before COVID is saying, you all are burning out. So we're going to require this mandatory yoga class for you. Right. Mandatory 14-hour, what do they call them? Before webinars were cool to tell you how to deal with burnout. And that 14-hour thing that you don't get paid for
burns you out more.
Out even more, and it's mandatory or you can't practice here. That is abuse. It all wraps all around the whole problem. That's why I said the bottom's about to fall out of this mother.
Well, let's
I agree.
I don't know where it's going.
Don't worry, I'll just bat the trolls off Twitter. Keep going.
Also,
we'll probably get censored on YouTube, but I don't care.
Dr. Yogendra, go ahead.
I was going to say, and it just kind of follow up on our discussion on this. When we're talking about some of these new drugs or these new experimental drugs, the first thing every doctor is going to say is, oh, you know what? These biotech companies, they have their investors and they have nefarious reasons and financial reasons. And that is the reality. There's CEO speak and there's actually clinical reality. And I think we have to be careful about how we get that information and not push it to these physicians. Because honestly, when I talk to them and say, look, I'm not paid by any biotech company. I kind of wish I were. I would, probably be able to pay some of my loans off. But, and then that's how I always start with that disclaimer, just to let them know I'm not on behalf of this company, but I do think these drugs are kind of interesting. And you start having those discussions, but I'm just one doctor just having them. I think if we have all of us having, something, Dr. Drew, you said many months ago to me really resonated. Is doctors don't talk to each other. Well,
I was going to say that's why I enjoy these conversations, because the team, working with subspecialists and things, that's how I kept my razor's edge. That's how. And all of a sudden we're just not talking to each other, or we have
fighting with each other,
silly opinions about things. Where I don't know. I agree with you. And it's just the three of us talking, just even if some of it is just sort of unloading.
Yeah.
It feels pretty good. It really does. So, and it's we're talking about stuff that our peers are not sharing because, like you say, they're afraid. But I got to wrap up. I got to say, guys, Dr. Yo, thank you for stopping by. Go to covidlonghaulers.com or follow Dr. Yo at Yo, the word Dr. Yo. There it is, all spelled out. And Dr. Emily Porter, let's bring her on up here. Where would you like people to go? They
can read my Twitter. I'm kind of funny. I talk about my kids sometimes. But...
You are funny. And speaking of which, you were talking earlier about the pressures of corporate medical groups and stuff. They don't get on you about some of the stuff you say?
I work for a private group.
Oh, so. But you're okay. Do you have to clear that stuff with anybody? I mean, do they get on you?
He's I've got one boss. I know him by name. He still practices in his own ER, and so we don't have to worry because there's no bigger bureaucracy than just me and him. So we're good.
So that is at Dr. Emily Porter, EMILY Porter MD, at Dr. Emily Porter MD. Panda Loco, I would love to see Andrew Yang as mayor of New York City. Yes, I do support him in that endeavor strongly. If he'd like to come on here, we'd be happy to talk to him, by the way. But you guys, anything before I close it out? I have my COVID stuff. I literally have to go lay down after the conversation. It's just so ridiculous. Like, you're laughing, but it's where I'm going. I'm going to bed.
My husband's working in the ER tonight. He picked up a shift because somebody covered one of his when he had COVID, and now somebody's wife's having a baby, which means I have to do bedtime for my 4 children.
Oh my gosh. Well, good luck, and thank you for joining us. Dr. Yo, it's always great to talk to you, and for everyone else, we appreciate you on the stream. We've been watching. Thank you to Zoe Mack, and thank you to those of you who've been doing super chats. We really appreciate that. And
Flipping Birdies.
Thank you, Flipping Birdies. You've always been very supportive. And we will be in here tomorrow, correct, Susan? No, tomorrow's Friday. No, we will not be in here.
And then we'll be back next week. We have some good guest lineup.
Probably on Tuesday. Is that right?
Yeah, it's a holiday weekend.
I got a lot of things I want to get. And by the way, if you have suggestions, send it to contact@drdrew.com. We'll bring in. I want to broaden out the topics we're getting into. We've done an awful lot of COVID, and
then also tonight at 7 p.m. we have a special report with Dr. Drew and Alex Michelson at 7 p.m. at actually it's foxla.com/live.
Very good. Miss Dunn says Shabbat Shalom. I've noticed people are getting more religious all of a sudden. Like they've really all of a sudden there's been a turn. Like in the last 2 weeks, while I was lying there sick, I was studying social media in my stupor. And maybe we'll bring that up as a topic with some faith-based something and see if they have any ideas about what's going on.
I'll send you my tweet about not going to Christmas Eve Mass, which turned out to be good because we all were brewing COVID, but I took a lot of flack for, okay, I'll say it because we got 2 seconds. It was, I don't know who needs to hear this, and I'm Catholic, but Jesus is okay with you dipping a cracker in some Merlot tonight and watch live streaming Mass. Because it's the middle of a pandemic, and I got so much flack from, people who aren't even religious and who aren't even Catholic. It's a joke. It was a joke.
That's so ridiculous.
I didn't go because we would have infected the whole church. Turned out we had COVID.
Thank God you didn't. Jokes are good, everybody. That's called comedy. If you don't have a sense of humor, that's on you. But yeah, I think there's something brewing right now where people are looking for meaning and direction, and something's up. So maybe next week we'll get into some of that stuff. All right, guys, thank you so much, and we'll see you next week. Well, I too have struggled with GI issues over the years. I have something called Lynch syndrome. So gut health is extremely important to me. And while gut health awareness has increased, it's led to a wellness trend that's inspired a host of questionable marketing and some false claims. Now, you've seen the word probiotic attached to all kinds of supplements, drinks, even more. They may claim to deliver the healthy microorganisms our gut needs for proper function, but all too often the promises are in fact too good to be true. Thankfully, I became aware of a company called Seed and their flagship product, the Daily Synbiotic. Seed's Daily Synbiotic offers 24 clinically researched strains of microorganisms in a single dose. These strains support gut health and can improve regularity and relieve bloating, sometimes within as little as 24 to 48 hours. To me, what really sets Seed's Daily Synbiotic apart is the delivery system. While some products may offer the right strains, they're fragile, they rarely survive the trip through the gut, doesn't get where it needs to go, but Seed uses a capsule-in-capsule design that helps ensure the probiotic reaches your colon, which is where they often are needed. I've been taking Seed's Daily Synbiotic, and I really encourage you to check out their story and the science behind what they do. To try it for yourself, just go to seed.com/Dr. Drew. Use code Dr. Drew 20 for 15% off your first month of Daily Synbiotic. That is SEED.com/Dr. Drew. Use code Dr. Drew 20.